Good afternoon. Welcome to today's webinar entitled Managing Stroke Care During the COVID-19 Crisis, Evolving Solutions, presented by Dr. Ameer Hassan and Dr. Devlin. Your webinar will begin shortly. If you are disconnected from the webinar, you can re-enter the program at any time by following the instructions that have been provided to you. If you are still having difficulty connecting to the webinar, you may call our technical support hotline at 1-877-992-7225. Again, that phone number is 1-877-992-7225. If you have questions during the presentation for any of our presenters, you may enter them in the Q&A box in the layout below the PowerPoint presentation. We will also have a verbal Q&A at the end of the presentation. As a reminder, this course is sponsored by Medtronic Neurovascular, and as such, no off-label discussions are permitted. If you have any questions pertaining to off-label use, please direct them to rs.nvoma@medtronic.com. Now I'd like to introduce our speakers for today's webinar. Our first speaker is Dr. Devlin. He is currently the chairman of the Department of Neurology at the University of Tennessee College of Medicine in Chattanooga, Tennessee, and the executive director of Chattanooga Network for Stroke. Our second presenter is Dr. Ameer Hassan. He is currently the head of the Neuroscience Department, the director of Endovascular Surgical Neuroradiology, and the director of Clinical Neuroscience Research at Valley Baptist Neuroscience Institute in Harlingen, Texas. We'll get started with Dr. Devlin. Dr. Devlin, the floor is yours.
Thank you very much. Welcome all. Good afternoon, and thank you for joining Dr. Hassan and myself today. Would like to send out a special thanks to Medtronic for hosting this event on this really unprecedented time to talk about acute stroke care and COVID-19. Next slide, please. Next. Disclosures, and next. So according to Johns Hopkins Resource Center, from a global perspective, COVID-19 cases are still increasing at an alarming rate. As of today worldwide, we have over 1.2 million confirmed cases with a mortality rate of about 5.4%. As you see in the two yellow graphs on the right, not only are the total number of cases increasing, but the daily rate of new cases continues to climb worldwide. In the United States, where we have over 330,000 cases as of today, COVID-19 is spreading through both urban and rural areas. So this is an enormous problem that each and every one of us and our hospitals face. Next. From a hospital's perspective, the CDC estimates that somewhere between 2.4 and 21 million people in the U.S. may require hospitalization. But with only about 925,000 staffed hospital beds currently in the U.S., hospital resources are predicted to quickly be overwhelmed, particularly ICU beds. This will occur despite the recent relaxation of the regulatory barriers to expanding hospital bed capacity. Resource utilization at hub hospitals must focus on treating primarily those patients needing higher level of care. Next. Next slide. In fact, resource allocation will be the biggest challenge that we face. According to the Johns Hopkins Center for Health Security, I quote, "The arithmetic suggests that we will outstrip hospital resources, particularly intensive care resources, in ways as the pandemic spreads." Next. And at both spoke and hub hospitals, we will be hit financially very hard due to a combination of both skyrocketing prices on supplies and operating costs and massive revenue loss due to canceled elective procedures and office visits. Next. As stroke is the #1 cause of adult disability in the United States and the #2 cause of death worldwide, the impact of COVID-19 on stroke care specifically is a particular concern. Our ability to rapidly diagnose and treat stroke patients will be challenged in this increasingly busy ER environment at both spoke and hub hospitals. Based on worldwide experience, particularly from what we've learned out of China, we can anticipate that the presence of on-site neurology consultative services in the ED is expected to drop. This will seriously jeopardize stroke care on multiple levels, including prolonged door to TPA times or missed TPA treatment altogether, increased LVO recognition times, and increased symptom onset to groin puncture times. Next. From the recent experience published in Stroke by Zhao and others out of Shanghai, China's largest city, they saw a significant drop in the number of stroke neurologists working in the EDs and a 50% decrease in mechanical thrombectomy cases compared to the same period from the previous year. So based on the Chinese experience so far, we have great reason to be concerned about stroke care here in the States. Next. The message that is being disseminated from our stroke national societies is entirely clear. They're saying that we need to redouble our efforts to maintain high-quality stroke care in the era of COVID-19. SNIS just published a position statement that stated, quote, "The presence of COVID-19 as a public health issue should not alter the inclusion and exclusion criteria for mechanical thrombectomy. Denial of this treatment likely creates a greater drain on healthcare resources." And the AHA just published its own statement on March 31st entitled Acute Stroke Care During COVID-19, AHA's Emergency Strategy, where they state, quote, "Continue treating stroke patients as appropriate. Full adherence to guidelines may be challenging, but needed treatment should be offered to the extent possible." In that statement, importantly, the AHA guidelines and guides us that says that health and safety of our staff is of paramount importance. And in order to minimize the use of scarce PPE, we need to send the fewest possible team members to stroke codes and for stroke follow-ups in their rooms. And they strongly recommended the use of telemedicine. The AHA statement also reminds us that the NIH stroke scale can be performed efficiently and accurately via telemedicine, and this technology is highly recommended, not only at spokes, but also for its use at hub EDs. Even the group from Shanghai at the epicenter of the COVID-19 crisis themselves recently published the following quote. They said, "It cannot be right that treatment for one potentially curable disease, namely stroke, is euthanized at the expense of another. With COVID-19 becoming a pandemic, the world needs to act quickly to have plans ready to deal with the challenges of continuing to deliver high-quality stroke care." Next. So with this background, let's focus on what should be the central goals of stroke care in the era of COVID-19. So while the number one goal is to try and maintain quality stroke care and fast treatment times for TPA and mechanical thrombectomy, we need to focus on protecting the limited resources at the hub by avoiding fetal transfers. So a fetal transfer is defined as that patient whose care could be adequately managed at the spoke hospital but was transferred anyway. With COVID-19 now, the critical need to avoid fetal transfers, which can account up to as much as 30% or more of our patient transfers, takes on a whole new importance. Fetal transfers serve only to further stress an already overwhelmed hub hospital system that has limited bed capacity, staff, and particularly limited ICU space. Next. Secondly, we need to focus on protecting patients and our medical staff. So some of the key facts to remember that dictate what our protocol should be are the following, and they're somewhat daunting. Number one, stroke patients, because of their comorbidities, have both a higher risk of acquiring COVID and a higher mortality. Number two, the recent collaborative study from CDC, NIH, UCLA, and Princeton demonstrated that COVID-19 is detectable up to 3 hours as an aerosol, possibly in an emergency room, for example, 24 hours on cardboard, and 2 to 3 days on plastic or stainless steel, like a gurney that your EMS may be pushing into your ER. We also know that COVID is transmissible from asymptomatic contacts and that EMS workers are particularly at high risk given their potential exposure. Fourthly, according to CDC, in the 2002 SARS outbreak, 20% of cases were healthcare workers, and we are already seeing an alarmingly high rate of infection in workers at some of our U.S. hospitals. It's been reported, for example, at Vanderbilt that there's over 80 healthcare workers that appear to be infected. So our goal in the hub and spoke model should be to quickly screen patients at the spokes for LVO, avoid futile transfers that put EMS, clinicians, and patients potentially at unnecessary risk. Next slide, please. Next slide. Next. Erlanger was the first center in the United States to have implemented the artificial intelligence deep learning-based LVO screening technology called VIZ.AI. Over the past 2 years prior to COVID, we experienced a total transformation in the workflow throughout our acute stroke care system. Given the impending traumatic surge in critically ill patients to our hospital, we believe that the VIZ technology takes on a new level of importance. And based on our experience, we've learned that VIZ.AI can greatly assist in helping us with many of the key problems in stroke care that I've been discussing here so far today. Next. Within 5 minutes of doing a CT-CTA at an outside hospital in the ER there, at one of our spoke hospitals, we received high-resolution neuroimaging in a HIPAA-compliant PACS-like app viewer on the phones to all of our team members at the spoke and the hub hospital. The 3D viewing ability of the CTA within VIZ allows us to rapidly perform very high-resolution interrogation of the cervical and the intracranial vessels, wherever we would consider an emergent endovascular intervention, where the vast majority of our treatable lesions typically are, providing an extra fail-safe to facilitate LVO recognition if one of our team members happens to be distracted caring for another patient. The built-in text-based communication system within VIZ then allows us to rapidly communicate between the hub and spoke as for the need for transfer, and this has shown to specifically decrease our door in and door out times for our LVO patients. It also allows our entire hub spoke neurology and interventional teams to coordinate patient care. So overall, our experience is that VIZ greatly facilitates LVO detection, interfacility transfer, initiation of mechanical thrombectomy, and avoidance of futile transfers. For patients presenting to the hub center directly, to our hospital directly, VIZ greatly facilitates our remote presence evaluation and facilitates our treatment decision making process and the execution of our mechanical thrombectomy. So with those thoughts in mind, I'd like to turn our remote podium over to Dr. Ameer Hassan, who's going to talk a little bit about his experience working day and night, taking care of his stroke patients down in Texas. Dr. Hassan, if you could join us, please.
Yes, thank you, Tom. Great presentation, and honored to follow such a nice talk. So just to give you a little oversight, this originally the idea came about a few weeks ago to do some sort of CME for everyone and talk about building an efficient program. And then slowly this turned into why not add a little bit about COVID and then our use of VIZ.AI and how we've improved our treatment and triage. So overall, the conversation will go something like this. Our early experience utilizing AI did show significant reduction in transfer times as well as length of stay. And this is more important than ever today with COVID-19 and trying to utilize resources appropriately. Here are my disclosures. So just a little bit about us. We did about 200 mechanical thrombectomies last year. We now cover 2 CSCs, about 1,200 neuro cases at Mothership, the primary CSC, 3 interventional neurologists. We have 3 biplanes, which worked out very well during this COVID-19 era, and I'll go into a little bit of detail since we have now a dedicated biplane suite just for COVID potential patients. And then, of course, we've been involved in a lot of the research that you all know about. So just to give you another idea of our program and what we have to deal with. So we're Valley Baptist. We're all the way down here where you see Valley International, the little plane under number 11. And then these are all the hospitals that have transferred to us over the last few years and that continue to transfer us. So we cover a large encatchment area, a large surface area, and sometimes it's not the best thing for patients or their families to kind of drive all the way if it's a futile transfer. We're not going to be able to offer anything to benefit the patient. So we'll go into a little bit of that as well. So just to give you a good overview of the estimates of thrombectomy. So this is the current state, the treatment rate going on in 50 of the biggest U.S. metro areas, and we show the highest rate and the lowest rate. So as you see, the Denver, Aurora, Lakewood, Colorado area has the highest rate of utilization of mechanical thrombectomy, 9.3%, which makes sense. You know, our friends and colleagues over there are doing a great job. They've done an excellent multi-hub and spoke network using telemedicine, and they cover up to Montana and several areas, states and cities. Buffalo and, of course, San Diego, and as you go down the list, these are very high-volume centers. Most of them are well-known academic programs as well, high-enrolling sites into most of the studies. Then on the other side, you have the lowest rate. And some of my friends are on this call who might be from Washington, D.C. area, where it's getting a 2% utilization rate. San Antonio, which is about a 3.5-hour drive from us, 2.1%. And even Boston is 2.5%. So we really have a lot to work on in order to improve the utilization of mechanical thrombectomy in today's current market. Now, here are some of the issues with volumes, and these are the challenges. Yeah, I'm sure most of you have read the Stratus paper written by Michael Froehler, published in Circulation, about treatment times and patients that were either direct to a mechanical thrombectomy center or CSC versus patients that were transferred. And there's a significant difference, 3.8 versus 5.2 hours in those times. There's an increased cost related to mechanical thrombectomy. Every minute you save in treatment leads to almost $1,000 benefit. Bed shortages. So we all have increased volumes going on, even pre-COVID-19. And now you have, on top of that, the futile transfers and the lack of ICU beds. Thankfully, in Texas, we're not that bad. I believe we're a little over 6,000 cases total. We're about 180 in our encatchment area. It's about 5 counties. I think we reached 198 positive cases today. We've only treated 1 positive COVID mechanical thrombectomy so far, but we still treat every patient as if they're COVID positive, and we're being very frugal with the resources, right? We don't know how long this is going to last, so you need to be protective of your ICU beds, your ventilators, and your PPE. And then, of course, provider burnout. Even though I think EMS and nurses are the real frontline heroes, you know, we get tired too. I've been on call for a few weeks, as you can hear in my voice. So we don't want alert overload. We don't want to be called for every potential patient that's going to be a futile, already infarcted tissue, you know, 2 days out. We don't want to be glued to the hospital. We don't want to be overextended. A lot of us cover other services, whether we round in the stroke unit, whether we read images if you're a radiologist, or in my case, I cover neurocritical care. So we all know that time is brain. I'm sure you've all seen versions of this slide, but just want to emphasize that every 20-minute decrease in treatment delay is a 3-month gain of disability-free life. And as Tom had mentioned, one of the nice things that I really loved, you know, Justin's paper for SNIS, it really emphasized that just because of what's going on in the current pandemic, you should not delay any stroke treatment. I mean, stroke is, not only have we proven it's beneficial, but there's significant cost savings. Clinical correlation shows that, you know, we have the 20-minute decrease in treatment time, 3-month gain of disability-free life. That leads to less stays in the ICU, less stays in stroke unit, in the hospital, in physical therapy, and just so many reasons why you should not, besides the fact that you're actually going to benefit this patient. Obviously, we know everything is going slow. For those of you who have seen my presentations through the years, I'm a car guy, and this is a Yugo. And everything historically went very slow. To be honest, most of us have been together and done a great job over the last few years with the newer studies and showing the improvement in care. But in general, things I still believe go slower than we would like. Also, we were amateur gunslingers. I truly believe that we overall have improved our techniques, our processes of care. That's one of the reasons why we developed the STEPS-T program. Really just the techs, the nurses, the physician, the fellows, what everybody should be doing. This is just a picture of all of us at University of Minnesota during my training. So here's some of my COVID-19 recommendations. I wanted to hit this before going into the abstract that was presented at ISC. So we're going to break it down to pre-hospital care, consent, airway protection, room preparation, intra-procedural, radial access and groin checks and things like that, and post-procedure. And of course, for airway protection, there will be a little debate because I don't agree with most of what everybody says. So for pre-hospital care, the key here is I really don't care anymore if they've traveled to China or Iran or Italy. If you've had any travel in the last 14 days, if you have an active cough, if you have fever, shortness of breath, or acute respiratory distress, or potential exposure to any COVID-19, that's it. For me, you're a possible patient, and you're going to be covered with a mask, and we will have a lower threshold to intubate, but we're not going to intubate everybody. If there's a positive symptom, this patient should wear a mask, placed in isolation in negative pressure room. We'll discuss the debate of intubation on the next slide. If telehealth is available, so for example, our hospital, we do use telehealth at night and in the ED. It's a burden. Our neurohospitals team is really stretched thin. I think they have like 11 new consults today on top of a census of 20-something patients. And that's just stroke unit. So we use telehealth to handle the ED. And really, for us, it's been a consistent workflow. We haven't had to change anything, thankfully, and it minimizes PPE use. So we think this is, if you don't have it, it's maybe time to think about it. Consent and healthcare proxy, this is our current standard of practice. We did not change this. So if a patient is consentable, we perform verbal procedure consent with a witness. We always include consent for anesthesia, just in case. If the patient is consentable, perform your healthcare proxy consent as well with a witness. Now, for airway preparation, it's good to alert your anesthesia team early of a COVID-19 patient or if he's a suspected COVID-19 patient. If the patient needs to be intubated. So for us, it's mostly, the patient might have aspirated already or a posterior circulation stroke. These are the patients for us that will get intubated, and they never used to get intubated in the cath lab. They would get intubated in the ED. So that, again, really hasn't changed much. The negative pressure room in the emergency room prior to coming to the angio suite. But for those of you that might want to lean towards intubation, don't do it in your angio suite. Do it in the ED or in a negative pressure room before the patient arrives to your cath lab. Review in advance whether anesthesia presence is required. We handle these patients. Myself and my partners are all neurocritical care trained. So for us, we manage these patients. They're intubated in the ED and they come up to us and we'll manage them. But if you want anesthesia in the room, just do that courtesy. I would not want to bring my anesthesia into the room with a patient who's awake, moving all over the place. We're pulling out mechanical, doing mechanical thrombectomy, pulling out a clot, and then, God forbid, the guy is coughing, aspirates, needs to be intubated, aerosolizing in the air. It's just a significant increased risk to our anesthesia team. So let's just get this done. ED is very comfortable doing this. They're ready for it. They've been doing it for a bunch of other things anyways, for most of the trauma. All of our bleeds as well are getting intubated in the ED prior to coming up and keeping that closed circuit. So this was presented by the SAIEV, I think, forgot the acronym now, but as you can see here, SNACC, endovascular therapy for acute stroke. So for them, if the patient has acute respiratory distress, active cough, inability to protect his airway, is vomiting, posterior circulation, or high NIH, they're going straight to general anesthesia. And then if you're doing that, induce GA in the ED, which I agree with, and that way you're not, risking your equipment or your cath lab space. Room preparation before the patient arrival. Have a dedicated room for all strokes. Whether COVID-19, again, possible, positive, or not. If you only have one room, we recommend you remove all unnecessary objects. We actually have 3 biplanes, so one of our rooms is a COVID room. We removed everything out of that room. It is literally bare walls with hooks. Nothing's in that room. Catheters removed, devices, extra lead, everything. We don't cover the countertops because we will, after the case, basically wipe down that whole room. There's a Again, we should probably add to the list of heroes our cleaning team, because really they're going in there and they're making sure to clean off the tops, the biplane itself, wiping down everything, the screen. Luckily, a few months ago, we ended up purchasing covers for our screens because one of them cracked when it was moving. So we have these covers that you can wipe with any type of material versus the regular screen. You don't want to use the cleaning material on top of that because it can decrease the film over the screen. Prepare all your procedural elements in your room before patient arrival. So we always cover the detector, the pedals, everything's covered with bags. The table's already prepped before that patient comes into the room. We do have an observer, so we're typically a three-man female, males or females team. There's the attending, and then we have 3 other people. So typically we have a tech scrubbed in, we have a circulating nurse, and then we have outside a monitor. Could be a tech or a nurse. Typically, this person would help if there's too many things to be pulled, they would come into the room. Now that is forbidden. It's the 3 people in the room, they're the only ones staying in the room. When we do come in, we bring in the stroke cart with us. And that way it's far enough away, so at least 10 feet away, it's on the other side of the patient, if we need to pull any additional stroke devices. We double glove, we wear face masks, we cover your eyes, we wear goggles, and we always wear booties. This is standard practice for us. This didn't change. Use the hanging lead shields. So we always put the mobile shield, it's a big, I think 7-foot shield that's rolling around. Anesthesia likes to borrow one. We have a second one just in case they're in the room with us. We always put that next to the lateral camera, and then you have the floating shield that we put between the patient's head and us, usually, about 6 inches from the groin. Hand sanitizer is always at the doors. This is standard, right? This is always going on. I'm sure all of you have this already in your areas. And then plan an area to place your phone and pagers and whatnot. We don't use pagers anymore, thankfully. But what we do is they'll wipe them down, and then the monitor will answer our calls during the case. And this is our standard of practice pre-COVID as well. So intra-procedure, keep staff to a bare minimum. Like I said, it's just one circulating nurse, the tech, and me. Nobody else is in the room. Conserve your PPE. That's the main thing. Since we have dedicated biplane for all strokes, everyone knows they cannot enter that room during a case. Pharmacy, the cleaning ladies, anybody. Nobody is walking into that room during a case, and they all understand why, because it's the COVID room. Now, we share our team with cardiac. When we built our program 8 years ago almost, we decided to work with cardiology because they had the STEMI set up and it was very good. They're very quick about coming in. So that room we'll share with them as well. So thankfully it hasn't been an issue over the last few weeks where there's a STEMI and a stroke at the same time. But if it does, we already now have removed the new biplane, the 3rd biplane, has removed everything from that room as a second potential room for potential COVID patients. Again, always observe everybody, providers doffing off their gown and gear, and ensure any trash is completely inside the bag, tie the bag inside the room and get it out. Last but not least, we have the importance of the neuro as well as the groin and radial access site checks. This is extremely important. My partner and I converted to radial probably almost a year now. For our strokes, it's mostly posterior circulation strokes. We don't think it's fast enough for the anterior circulation strokes. So for those, we'll still get the groin checks. But just everything in general, all these patients, we are sending them to the COVID unit. Right now, it's not overburdened, but that way we're not wasting, again, PPE. Now, if your COVID unit's full, or if these patients are still going to your traditional neuro ICU, the idea was to limit exposure, right? So when the patient's handed off to the receiving team, have the gown provider check the access site prior to taking off his own gown and gear. That can count as either the 15-minute or 30-minute check. If you have telehealth, they can help you with monitoring, and it should be utilized. We don't in the ICUs. For us, we have our staff and our NPs. Consider switching your checks to 30 minutes. And then after maybe 2 checks up to 30 minutes each, then go for every hour times 2, and then every 4 hours. And just try to decrease that frequency. Post-procedure, this is important, right? This is a debrief with your team, learn from each other, especially if you have a big practice, multiple fellows. If one person made a mistake, we should all learn from that. You shouldn't be repeating mistakes. In our group, we do have a fellow, and we are 3 personnel. We have almost 16 cath lab personnel. So there's a lot of people. So when we pick up any one of these potential patients, immediately we walk out of the room and say, how we could have made this better. And I think everybody's benefited from that. The other thing is wait for the cleaning staff 30 minutes. We have heard from our engineers that our room filters air 4 times an hour. So again, that's per engineering. I would ask your engineers as well in your institution. So 30 minutes should be more than enough time that cleaning staff can go in there and they'll be fine. In our hospital, all these patients go to the same unit as I mentioned, but if your units get filled, then you can limit the transport to the other units. And then in the end, take a break. This is psychologically tough. I mean, when we had our first, I knew this patient was going to be COVID. I don't know why, but I had a feeling, and it was psychologically tough, right? We all go home, and even our staff, right? We practice best practice. We change our scrubs. We change in our garages. We walk in our house in our underwear, go straight to take a shower. Minimize contact. I know some people are taping, like literally with red tape in their house. This is the area that, their kids and their family members know not to go in. These are all important things. I don't know how much exposure you have to COVID-19 patients, but you want to make sure that you protect yourself and your family, because we can't have physicians and nurses and techs and EMS and everybody dropping like flies, especially now with, some of us with potential exposure. They're saying if you had potential exposure and you were not protected with PPE, you have to leave the hospital for 14 days. That is going to significantly affect your staffing. So these are all things to think about, and we'll move on. So now back to the original topic. So how do we make our program better in order to treat more patients, treat them faster, and treat them better? And it's obviously technology. We had this pictures from a previous paper we wrote, and from angio suite to recan, we called it the STEPS T. And it was a standardization of our processes. And with technology, we were able to significantly improve the setup time, puncture to recan time. Also, the improvement in technologies, improvement in devices. Your X71 travels way better than, ARC did. So technology has improved as well. Now, the big problem was always door to angio suite time. I mean, we could try to do whatever we want between angio suite and recan, but that was still only a small picture of the problem. So what do we need to do? We need to improve detection, and we need to improve transfer times. And doing that will improve your door to recan treatment time. So for those of you who don't use VIZ or haven't seen it yet, these are just examples of the screenshots. This is what it looks like when you get a push alert on your phone, the left screen. And then this is the VIZ elbow. So as you can see, there's a left MTA occlusion here. You have the CTP analysis, which, typically we actually get before the elbow alert sometimes. So we like that, and we appreciate it for screening patients for potential studies. You can also review the CT head. So the non-con head is immediately available before these other images are, whether it's elbow or CTP. The VIZ hub, which I think is probably the most important thing we use, it's a HIPAA compliant texting feature. Our ED, our transfer site ED. So if the patient comes from a transfer site, those ED docs are on that group. The research nurses, it just makes it so much easier, house supervisor, to get everybody organized and everybody knows what's going on with one message versus, the 5 or 6 phone calls that used to occur. And we'll go through some of that process in a sec. So solutions for faster treatment. Technology helps synchronize care and promote early detection treatment. So target stroke reduced in the reduction door to needle time was about 15 minutes. Using the Mass General Quality and Safety, reduction arterial puncture was 36 minutes. With VIZ.AI, we've seen reduction of 52 minutes to specialist notification. And this is with a specificity of 89%, sensitivity of about 88%. So this is the abstract that we presented at ISC this year, early experience in utilizing AI, showing reduction in length of stay as well as transfer times in a hub and spoke model. So our study rationale was that accurate and fast detection as well as triage of elbows is critical. Now VIZ came in, to be honest, it's one of those things where I was a little concerned, right? I thought I was overpromised, and it really did deliver. It was able to automatically detect the suspected elbows at our spoke and immediately alerted us versus, as you can see here in some of the slides I'm going to show you in a little bit, the old process of the transfer time. So your CT is done, it's pushed immediately to the cloud and then pushed to everybody in the network. So the stroke specialist, I get alerts on my iWatch, my Apple Watch. Android lovers and Apple, iPhone, it works with everybody, but for watches, I think it's only for the Apple Watch. What you see is a single center retrospective study compared patients with elbow who presented to a PSC and were transferred to pre and post VIZ implementation. We were assuming we're going to have better outcomes because we did see this. We saw this live as Brownsville, Valley Baptist Brownsville was implemented. Patients were coming much faster. There wasn't a lot of red tape that we had to cut through in order to get these patients appropriately screened. So yes, so this is probably the most important slide when it comes to improvement in stroke triage at a hub and spoke center. And what you see is here, patient arrives at a PSC, they're performing their NI-stroke scale, they get the CT and the CTA as per their protocol. And we have great docs there, great nurse coordinator, great ER docs. I mean, it's a very good team over there. But even with that, with years, we spent 5 or 6 years working with them, trying to improve that first step in order to get the patient and get the patient to get the appropriate study and get our phone call. Even with that, from February 2017, and I've been working with those amazing guys and gals since 2012. So for 5 years, we've improved this pretty well. So if you look at February 2017 to November 2018, the process was still a little archaic, right? The CSC physician is called regarding a possible elbow when they push the patient to CTA. But then they wait for the radiology tech to reconstruct those images. Radiology calls the ED physician. The ED physician, not the stroke doctor, me. Radiology would call the ED physician and tell them, yes, that CT angiogram you ordered, there's a large vessel occlusion. ED physician would call, typically, the neurologist who's at that site, who then would call me, who then calls the house supervisor. House supervisor calls them to initiate the transfer, and the patient is transferred to us. Now, the CSC physician confirms large vessel occlusion on VIZ. I get the push alert. I see it's a large vessel occlusion. The house super's on it. Through the texting, through the VIZ hub, we're like, hey, bring this patient over. That's it. Patient comes, gets tagged in the ED, screened just in case if they need to. Airway evaluation is always done in the emergency room before they come up just in case they need to be intubated. And then the patient comes to cath lab. We found a 66-minute decrease for primary stroke center picture to CSC door. 171 minutes versus 105 minutes. P-value is 0.01. 55% neuro ICU length of stay reduction. 3.5-day decrease in length of stay in the neuro ICU. P-value 0.0039. So this is pretty significant data. So as you can see here, the decrease in time, decrease in neuro ICU length of stay, and the 66 minutes saved. So overall, this has done a significant, I think a very, very good job of improving stroke detection and triage in specifically hub and spoke models. Now, if you tell me that you're going to get similar times in your CSC, I'm going to tell you you're blowing smoke because it's impossible, right? We have nurse practitioners, we have residents, we have fellows. I mean, our work is being done so efficiently in-house. It's usually the significant savings you're going to find is in that hub and spoke model, where they don't have residents or fellows and a huge team to worry about stroke patients. And as we can see here, there's a direct impact of that faster arrival time with decreased length of stay in the neuro ICU. So patient outcomes are time dependent. Each minute delay in thrombectomy results in a loss of 4 days of disability-free life, 10 days of functional independence. So while ongoing research is necessary, significant average of 66 minutes from PSC picture to CSC arrival suggests the implementation of VIZ did contribute to nearly 265 days of additional disability-free life with 660 additional days of functional independence. And now I thank you very much, and we'll leave it open for questions. And just so you know, we don't have only 60 minutes for questions. You know, we can run over, totally up to the audience. So I think for questions, I don't know if you guys can see on your screen, you need to dial this number, 877-876-9173, and tell them the conference ID is XYVID, pronounced ZIVID.
And as a reminder for the participants that are already on the call, if you would like to ask a question, please press the star and 1.
Thank you to both our speakers for their presentations. We are taking Q&A in 2 different versions. as Dr. Hassan said, you can call in and then verbally ask. You can also write in your question to the presenters in the box that is next to that notes box. So
I'm going to take one of the questions that's already typed in here. So what's the reasoning behind not intubating in the lab? So aerosolization, I don't know if you were present during the first couple of slides of Dr. Devlin's presentation, and he mentioned that it can stay in the air for a while. So as this patient is going to cough and gag while he's being intubated, you're aerosolizing that COVID-19 in the air, potentially making everybody at risk, just not only the operators, but the person who's intubating, and then potentially the cleaning ladies as well.
In reference to the question, do you feel that patients are waiting too long to come into the hospital with a stroke due to fear of getting COVID-19? The answer to that is clearly yes. The Chinese experience this widely in Shanghai, and in their recent paper in stroke, they said that one of the things we have to do as stroke centers and leaders is to reach out to the public and to remind them that they really do need to come in, that this is a life-threatening condition potentially. So many centers across the United States actually have seen a drop in their stroke volume, even though, and one of the things that can be very difficult, we're very concerned about, we're just beginning to learn about, is that COVID itself may present with focal neurologic symptoms that mimic stroke. And the tricky thing is that some of these patients have fever and other symptoms, but sometimes it may be primarily stroke symptoms itself due to an increased thrombotic hematologic condition from the COVID. So we do need to reach out to our communities and remind them that the presence of COVID should not deter them from calling 911. Dr. Hassan, question for you. Have you changed? Yes. Have you changed your practice in the emergency department at all for your stroke team that's first responding to stroke patients? As of just a few weeks ago, many hospitals, the stroke patients, particularly in a well-oiled system, they're coming right off the ambulance, they're coming right off the helicopter, they're coming right back to CT and not necessarily being screened. But what are you doing differently in your emergency department?
So great question. So the seeing now is the patients, for example, who are picked up from home, did have family members, were able to get a good amount of information. Those are still going the same route. Immediately on the EMS stretcher, straight to the CT. Patients that are questionable, meet any of our criteria that we mentioned earlier that could be COVID positive or potentials, those are going into the trauma bays, which are negative pressure rooms, and they are being screened appropriately, and then we are deciding whether or not to intubate there, and then prior to CT.
I think one of the concerning realities is that just wearing PPE alone may not present 100% protection for our CT staff, our neurology team.
Exactly.
In the neurology teams, where there's a loss of, if you lose one or two doctors on a neurology team, nurse practitioners, nurses, that can really hit home and be a problem. So I wanted to applaud AHA and Pat Lydon for recommending as one of, I think there are 4 initial points, that we move forward to a telemedicine solution as much as we can in the ED to try to protect as many people as possible and to minimize use of PPE.
Yes, and a very important fact that we need to be frugal, honestly, with our resources, with our staff. So if there's a patient that's extremely high risk, did travel to one of the areas or has acute respiratory distress syndrome, no hesitation. Intubate that patient, close the circuit, and you now decrease the risk on everybody else. But now, whether or not we should be intubating everybody going to cath lab, I don't agree with that, only because we do have an issue with ventilators. We know that some of our patients might be a little bit harder, even if it takes just an extra night to take them off a ventilator. You're decreasing the amount of resources that are going to be available for potential patients that do need it. I wanted to mention one thing. So go ahead, Tom.
I wanted to pose another important question that came up and get your thoughts on this. Do you think that rapid tests for COVID, serologic tests, would change your practice? How are you using these tests for triage, and how do you feel about the accuracy?
So that is great. I was actually going to read that same comment, and Francisco's a good friend of mine. Make a long story short, we don't have the rapid testing available yet. We're hoping to get it soon, but I could see it significantly helping us decrease the amount of PPE wastage, right? Because now you're going to know for sure within 15 minutes if this patient is positive or negative, and then everybody in the cath lab doesn't need to wear N95 mask now. So I think it will be very important for our resources, whereas I still think I would be moving things the same way.
Certainly the accuracy of those tests are going to be very important. Until we feel that the tests are highly accurate and very fast, certainly the very best way to flatten the curve is to test everybody, test our hospital staff, test our patients. That really would be the ideal situation, but I don't think many of us are anywhere near where we want to be in terms of the speed of getting these tests back.
Yes, and a couple of good questions here. So what delay would you say is acceptable for delaying times to treatment, considering you need to wear PPE screen COVID for thrombolysis and thrombectomy? So our cutoff is basically 15 minutes. We think that's acceptable. Anything more than that's not acceptable. And we're pretty good about everybody donning and doffing their protective gear and doing the appropriate screening, taking that 5 minutes to ask the right questions. In this day and age, we do need the cath lab team, our hospitals, our nurses, everybody to stay safe. So yes, I am always pushing to speed things up, but I'm glad someone posted this question because we really do need to be a little bit responsible. 15 minutes and take your time and protect your team and ask the appropriate questions. And just real quick, somebody also did mention, do we extubate the patients in cath lab? Never. We never extubate a patient in cath lab. That's even before COVID-19. These patients would always go to their ICU bed or PACU. Now we're not going to PACU. They go to a negative pressure room, the COVID units, or one of the negative pressure rooms in a neuro ICU. And if they're ready to be extubated, they would be extubated there. Tom, you there?
I am. So, Todd, thank you for submitting this question. Ameer, what delay would you say is acceptable for a delay in the time of treatment, considering need to the PPE? Are you, so is 15 minutes your cutoff?
Yes.
And what about for thrombolysis?
So that's also a great question. So for thrombolysis, and we've written a bunch of papers on this before about the groin to recan times. So for us, I would say 98% of cases stop within 60 minutes. Now, our average groin to recan is pretty good. I think we're around 18 minutes. But if we need to do multiple passes, if we need to do acute stenting, whatever it is, we've noticed that once you pass that 60-minute mark and you've done multiple passes, all you're doing is increasing the risk of hemorrhage, and these patients typically had significantly worse outcomes. So we have a 60-minute cutoff, Tom.
One of the things that's interesting about telemedicine, as you've looked at the effect of telemedicine across the United States, telemedicine is able to provide services 24/7 very quickly. And we've always prided ourselves at Erlanger, where we have a neurology attending in-house 24/7 on our 26-minute door to needle time. But if you look to see the effect of what telemedicine has done, they've done something very similar, but they've done it across the United States to far more hospitals than we treat. So I think the role of telemedicine in the era of COVID and keeping and I think this is why they're getting all the support from all of the stroke societies across the United States. It's very effective and it can be done very, very fast. So I think that's something we need to use more of, particularly in our emergency departments to keep our patients safe, keep our doctors safe, and to minimize PPE.
I agree.
Are you doing?
So, Tom, yes, a question for Dr. Devlin. Has your approach changed to how aggressively you investigate COVID-19 patients with echo as part of their workup for stroke?
Yeah, that's a great question. So the data is, the answer to that is no. It's an emerging field. We're following that literature. We know that given the fact that based on the prevalence and the positive predictive value, the test that we have now may not be that accurate. So that we're looking at CT and we're certainly looking at echo. Pretty much everybody gets echoed, but we haven't really changed our practice at this point.
And just one thing to notice, I mean, I don't know if there's been a lot of articles, so I'm sure you've been inundated with materials, but there was a great piece recently about the South Korean physicians and nurses who were tested positive and were asymptomatic. I mean, they would just wear a face mask. They would, obviously, wash their hands and do everything like everybody else did. But they found that they did not spread it to their colleagues as long as they wore a face mask. So I think that's also important to know that even for the potential patients, just putting a face mask on them will help decrease, the spread to your staff and, potentially echo techs and TCD techs and everybody else. So Mohammed, Dr. Al-Ghanem has a good question here. So we've noticed a decrease in stroke codes in general. I think Tom did touch on that they did notice that in China as well, and it's in published data. But what are your thoughts of why this is happening? What do you think of COVID-19 active patients are at higher risk of stroke as part of the disease process with cytokine storm? So there actually were a couple of publications on this, and one of them showed that they had almost a 5-fold increased risk of thromboembolic events. So I know there are a lot of papers coming out now, more and more of them. But yes, so there was a large center that had admitted a lot of patients in Wuhan that did show a 5-fold increase of ischemic events, specifically neuro, with cerebral venous sinus thrombosis and acute ischemic stroke. Whether it could be related to cytokine storm or not, well, I'm not sure. But we are seeing in the COVID positive patients, there is increased risk of thromboembolic events.
And there's a literature that's emerging actually on the potential benefit of TPA, knowing that the hypercoagulability that you get in the lungs of these patients may actually benefit from TPA. That's something we're following as well. Hasn't really changed any practice guidelines at this point, but that's an interesting finding. The other question that comes up here, Ameer, is some experts are recommending doing chest CT as you're getting the CTA of the head and the neck. Have you been scanning CT chest on any of your patients to date?
So we're not doing it, and there's been a lot of debate on this. I know, Tom's probably giggling right now because even for the SCIM's official response, which is currently under review, we were debating some of this stuff, and so we personally don't do it in our practice. I think it's just additional radiation. It's not going to add much, and most of our patients are coming in. I would rather take that 15 minutes and protect my team, and if the patient needs to be potentially intubated, intubate him and ask the appropriate questions prior to that, versus taking an additional 15 minutes to do a CT chest, which does not have very high sensitivity and specificity.
There's somewhat of a relative cutoff in terms of contrast and imaging by the radiologist. They'll either do say if we're interested or concerned about a PE in the lung at the same time we're doing a stroke patient, they'll do a chest and a CT and a CTA, but they don't like to add the CTP. So oftentimes you're swapping either a chest CT or a CT perfusion study. And in some of our cases where we need CTP, adding in that kind of extended time window, adding the chest CT may kind of tip the radiologist over their comfort zone. But we're not doing it either.
Okay. So I'm trying to answer some of these questions via the app. So someone wanted to know, is there any opinion or data about what population prevalence of active coronavirus infection triggers treatment of COVID undocumented with no positive risks as COVID positive? Until proven otherwise, for example, intubation outside the angio suite. So I don't think there is, I think it's more opinion, not data driven, where we would not want to intubate the patient in the angio suite. There is also other data that does show if you're filtering some people's rooms cath lab rooms, OR rooms filter the whole room 5 times or 6 times in an hour. So if you're having that kind of rate, then if everyone's wearing PPE and wearing N95 masks, I guess it doesn't significantly increase the risk when you're doing it in the room, but then you have to wipe down everything that's in that room. Whether the air is filtered or not, nobody knows what happens when he coughed and it aerosolized. How far is he from your rack with wires and catheters? So if you can do it in an outside room, even if you don't have a negative pressure room, just do it in a separate room. And that person who would be intubating obviously would be wearing a shield and full PPE N95, and then transfer the patient to the cath lab suite.
So, Ameer, maybe you could just underscore what we experienced with VIZ was a very dramatic transformation in our workflow of stroke prior to COVID-19. In the setting of COVID-19, it seems like about everything that VIZ does well is now even of more importance. The other thing that's interesting to see is what VIZ has done is now they've pivoted the company in part to develop a VIZ COVID-19 app. And if anybody's interested, I would reach out to the email address that we first showed on the screen to VIZ directly. But what they're doing now is they're using the same advanced communication platforms, not the AI deep learning models that we use for stroke, but the same principles of advanced communications between hub and spoke, which we've used very successfully over the last 2 years on the stroke side. They're now applying it and have developed an app to facilitate COVID-19 treatment at these facilities. I thought that was very interesting. But yeah, it sounds like from your data, particularly, do you have any comments about that?
Yeah, no, it's an excellent point. I mean, again, we didn't really discuss too much about futile transfers, but whoever is still logged in and looking at the screen, for example, the VIZ CTP. I mean, between that and the CT, we're big CT people. We like aspects. You can look at the image yourself and calculate an aspect and be like, okay, I'm sorry, we're full, or this is a patient who's not going to benefit from our services, and keep them at your spokes. That's really the big thing now, especially when you need to do a much better job managing these patients, because when a COVID-19 ARDS patient shows up at some of these spokes, they're transferring that patient no matter what, because they don't know how to handle it, and they want to send it to a higher level of care. And some of our transfer centers are in the middle of nowhere. So we need to be ready for them to help with the patients that they need the most help with. Whereas if it's a stroke patient who's already established his infarct and there's no penumbra, we're not going to be able to help that patient. Now, when it comes to the communication tool, again, I said that when I was presenting the slide, this is by far for me the most important tool. I mean, someone asked a question about, does your house supervisor, ED physicians, nurse, the neurohospitalist, the stroke coordinator, the stroke champion in the ED, everybody's plugged into it. So it really decreases the number of phone calls significantly. And you can put as many people as you want on this or as little. It's totally customizable. Another great feature of this. Now, the specific features for COVID-19 is just, yes, HIPAA compliant way of using, this feature, the VIZ Hub, to improve whether it's transfer or communication for potential COVID patients, and what to do with that, I think is a great tool. And if you want to test drive what VIZ is like, I think it's a great opportunity.
Somewhat of an unrelated question. Is anybody using UV for decontamination? I don't know that we use UV in our hospital for decontamination. I don't know the data for COVID-19 specifically. Are you doing that, Ameer?
No, definitely not. I know my wife has the phone soap, which is UV to clean my phone before I'm allowed to touch it once I come into the house. But outside of that, we don't use it at the hospital. So someone was asking a question about why not have all suspected cases, their CTs analyzed by the interventionalist. Again, you can customize the software any way you want. You want to get an alert for every CT stroke code, every CTA, every CTP. It's totally customizable. We prefer just, if the patient's getting the whole gambit of images, we only want the elbow alert to come through, and we actually make it alert us on every CTP that's processed. But we just don't go in and look at every CT. Unfortunately, that would be, very time consuming.
So another question back on this topic, could you just bring the normal stroke CTA workup to include the lungs? And would that be visible on VIZ platform? The answer to that's exactly what we just talked about, and that's what the VIZ COVID-19 platform exactly does, is it shares those images in very high resolution of the chest CT. I have to say, and Ameer, I'd love to get your thoughts, I've been really impressed with our ability to look at CTAs on the VIZ app on the phone. You would think, well, what can you see on your phone? I'm used to looking at a PAC system with a big screen. I dare say that I can see every bit as good on my phone as I can see on my PACS computer screen, simply because you have the three-dimensional rotation ability. So you can put the crosshairs on a certain point of, say, an M2, and you can walk around it in any direction you want, and you can see if it is an actual occlusion or if the vessel is just taking an acute right-hand turn, and it looks like it's occluded with a clot there, but really not. It's very easy to determine all of that on the VIZ app, and it's extremely good, I think, of scanning down to the carotids, right down to the arch and up in terms of assessing stenosis and visualizing plaque in the carotid and the common or the internal.
Yes, no, I agree. I think it's very easy to use. We love the 3D feature. It's easy to pinch and zoom. And what's interesting is, like, when I'm on just 4G, I know a lot of you live in markets that have 5G now, but we don't have it down here in northern Mexico. Even with 4G, I have no problem downloading this, and within 3 to 5 seconds, I'm able to go through, most of the series that I need to decide if there's a large vessel occlusion or not. Versus I know some of the competitors, it's just the download time and the buffering time is just way longer. Even with our old mobile packs.
Somebody said, I think that so we're using them to decontaminate the N95. So I'm excited to see there's questions and answers being posed here. So some people apparently are using UV in the setting of decontaminating their N95s, is what's commented on here. I can't comment on the validity of that, but that's what some people are doing. Well, I think we're at about 10 minutes after 5 here, and the questions seem to be waning here. So I'll ask our Medtronic partners here if there's any other comments that they would like to make, or Ameer. Is there any closing statements that you would like? Ameer, you've shared a wealth of information, as you always do. First of all, we'd like to thank you and everybody on the phone call for the truly heroic work that everybody's doing. There's no question about that during these unprecedented times. Ameer, you brought, as always, a wealth of information to us, and we respect and applaud you for that. Any closing comments, Ameer?
No, thank you very much, everyone, and just be safe. And I think it's very important for those of you, if, for example, this UV technology, if you're seeing that it is working and able to sterilize all of your equipment and your PPE, just quickly write it up and submit it, and that way we can push it through. There's a wealth of information to learn and to be shared, and I hope you all step up to the challenge.
And I would like to remind everybody is if they have any other questions, the original email address was that's R as in red, S as in Sam, N as in Nancy, VOM as in Mary, A as in Apple, at Medtronic.com. If you have any questions for either one of us or for Medtronic or about VIZ, please reach out to us, and we thank you very much. And I think that will conclude our proceedings from today. Be safe, and we will see you all very soon. Thank you.